Hello everyone. I bring you another video today, and this time we're going to be talking about obstructive pulmonary diseases, which specifically we're going to be discussing asthma and COPD. The first one is asthma. So what is asthma? Asthma is pretty much a chronic disease that is characterized by irreversible airway obstruction due to an allergen, or better say a trigger. In the page of your book, 542, you're going to see a list on table 28.1 of all the triggers that a person can react to. And these include from medications to foods to even the environment, such as cold air or dust, mold, to even emotional stress. There's different classifications. It could be intermittent, mild, moderate to severe. Some people have this only during allergy season. Other people have it constantly, and they have asthma that triggers maybe when they are around pets. And if you have pets every day at home, then you're constantly having this. It is more common in men before puberty and women after puberty, also in African Americans and Puerto Ricans. And as you can see the statistics here, thousands of people suffering from asthma a year, and many die from asthma. It is something very serious. It's a disease that in a way also is kind of debilitating. A little bit of the pathophysiology from this is that you have this trigger that causes this inflammation process. Oops, I switched the slide. Inflammation process. And then that causes some vasodilation, bronchospasm. You have the edema, the mucus, and then your airways become narrow. They become so inflamed and filled with mucus that no air, I better say, goes through it. It's almost like a straw when you're drinking from a big straw versus a very small, narrow straw. The amount of liquid that goes through the straw is minimized if it's a smaller straw. Well, the same thing with the pipe, our bronchis and all that. So, this is kind of like the picture of what it looks like. So you have this big pipe, open, nice, beautiful. When you have, normal in a normal situation, but when you have asthma, your muscles tighten. Then you have the swelling, you have the mucus production, and as you can see here, your airway is narrow, and so the air that goes through it is going to be minimized. If it becomes so inflamed that no air goes through it, then we have big problems, and it could lead to respiratory distress, failure, and death. So because the airway is so narrow and obstructed, that's where you get your symptoms from. So how does it manifest on clients? Well, the number one, we're going to call it the number one symptom or manifestation, is this wheezing sound that patients experience. So it almost sounds like this, like it could be an inhalation or it could be an exhalation, but you get that, very distinct wheezing. You can also have hypoxia, restlessness, anxiety, because people can't breathe, so they become very anxious. You can have cough, chest pressure, or tightness. The patients usually say, I just feel like I can't take a full breath, a deep breath. You might see them use their accessory muscles or some nasal flaring. And when it gets really, really bad, you might even see cyanosis or weak pulse and sweating. There is something called silent chest that your book talks about it. And pretty much what that is that if you're hearing someone have the wheezing and they're having an acute asthma exacerbation, and suddenly they stop wheezing, don't think that, oh, it went away. Like, oh, it magically they got better. No, think about, oh my God, their pipe is completely obstructed. So silent chest means a decrease or absence of breath sounds that might indicate a decrease in air movement or severe obstruction, which then you know that respiratory failure it's pending. It's coming up soon. So it is a medical emergency in a way. You really want to be able to assess and recognize it early. Now, there's also status asthmaticus, which it is a medical emergency. This is when patients have severe asthma, and it lasts for more than 24 hours and is not responding to any medications. And we're going to talk in a little bit about the medications, but just as this picture here shows, is an inhaler or a bronchodilator. So how do we diagnose asthma? Well, pretty much there's different things that we could use, but typically on a history of a patient and the assessments, a doctor can probably diagnose and suspect asthma on a patient. But I put a little star by spirometry. Pretty much this diagnostic test, it just provides an estimate of the narrowing of your bronchial tubes by checking the amount of air that someone can exhale after a deep inhalation. So pretty much it measures, you take a deep breath and how much air I could expel after that deep breath. They compare that before you do a bronchodilator and after you do a bronchodilator. And, there's some numbers there, an equation and whatnot. And if that basically tells them that your airways are narrow before a bronchodilator and opened up after the medication. There is a peak flow meter. It measures the exhalation of air from the lungs. We usually use this to see the severity of the patient. There's things as allergy testing and IgE levels. I did talk about allergy testing on your hypersensitivity reactions. So if you want to review on that, you can see that video. We can also look at chest x-rays and oximetry. Keep in mind that asthma is most often underdiagnosed. So a lot of people are not diagnosed because they don't recognize the symptoms and they don't seek medical attention. All right, so now that we have diagnosed asthma, then what do we do? So pretty much the goal for these patients are to identify and achieve and maintain control. First, you're going to identify what it's triggering their asthma. You're going to try to avoid it or eliminate it, and then try to achieve and maintain control of the symptoms. Family education and patient education, it's very important because not only do you have to teach them about what to recognize when they're in trouble, but also how to prevent it, how to treat it, and how to handle an emergency situation, what to do when. So positioning is very important. If you can't breathe and they're laying down, that's not good. You want to raise them up, make sure lung expansion, calm them down, use your therapeutic communication to make sure that, you're keeping them calm because it gets really anxious when they can't breathe. Provide oxygen, but I put in big red letters here that oxygen is only helpful if they have an open airway. So, for example, if your patient is having an acute attack right now, they have not received any medication to help them open their pipe and their airway, oxygen is really not going to do anything. Okay, so we need to open their airway first and then, kind of help them with oxygen. You can do something called pursed lip breathing. That's like putting your lips like this and almost like you're about to kiss someone and exhaling. That helps to bring the carbon dioxide out. You also need to teach them about inhalers and nebulizers. There is specific ways of handling meter inhalers versus a dry powder. We're going to talk a little bit about that a little bit later. And then also asthma action plans or care plans, kind of like what to do when, and depending on your symptoms, what you're going to take or when you're going to call the doctor. You also want to treat upper respiratory infections and sinusitis pretty quickly because those develop to asthma. Hydrate very well. Do nutrition, high in protein, high in calories, because you want to be well nourished, and then rest. Then, yes, we do have a medication therapy, depending on the frequency, the symptoms, and what you have going on. And then there's a desensitization therapy, almost like an immunotherapy, where you can desensitize the triggers so that way the patients don't experience acute attacks that often. The action plan is going to be on page 557 of your book. How to use an inhaler and nebulizer is going to be on page 554 and 555 of your book. You really need to understand that and review it. Also understand that as a nurse, we do assess lungs, we assess vital signs, oximetry. Maybe they might have to get ABGs. Also emotional support like anxiety, make sure they don't go into a panic attack, and involve the family on all of it because the family is part of the treatment as well. Here's how an action plan kind of looks like. You have your medicines that you do for green. Think about this as a stoplight. Green, it's good, like you're good to go. Yellow is like, you're kind of reaching a stop point here. You're kind of reaching that dangerous zone. You might have to monitor this and this and that, take this or that. And if none of that, makes you feel better, then you need to call the doctor. So that's why it says call your primary care provider. On the red, it's like stop. You're in the danger zone. Take the medication and call the doctor or visit the emergency room right away. So get familiarized with this action plan. The next thing that we're going to talk about is what medications do we give this people? And when you're studying the medications for asthma and also a little bit of COPD, I want you to differentiate them between rescue medications and long-term control medications. So I have put them here in sort of a chart, left and right. So we're going to start with your bronchodilators. There's rescue bronchodilators and there is long-term control bronchodilators. So your rescue bronchodilators, the one that if you have a patient in front of you and they're having an acute attack, you're going to give them is a short-acting B2 adrenergic agonist. We abbreviate that as SABAs, S-A-B-A. And they basically are your albuterols. Albuterol. Okay, these are your rescue inhalers. They're effective between 4 and 8 hours. Their onset is very quickly, within minutes. However, they work great, but they do have this little side effects that I want you to be aware of, and pretty much is high blood pressure, elevated heart rate. It stimulates your central nervous system, and you could get dysrhythmias. You also get tremors because of the central nervous system stimulation. So your patient might experience tremors. They might feel like something is funky inside of them, like they're just inches or some kind of like animals inside them in a way. And you're going to have those elevated blood pressure and heart rate. And that's totally normal. It's part of the medication. It's a side effect. You could repeat it every 4 hours as needed. Now you have your bronchodilators that are long-term control meds, and they're called long-acting B2 adrenergic agonists. And they also finish on terol, but they don't say albuterol. So pretty much these are your solmetrol, formometrol, etc. Okay, these are effective for 12 hours. They are not used when someone has an acute asthma attack. And most of the times they're used in combination with steroids. On the other hand, sometimes part of the medication treatment is to combine them with Sudafed. Sometimes patients have to their decongestions, but another classification is anticholinergics, and we do have rescue anticholinergics and long-term kind of anti-inflammatories. So there are two different classes, anticholinergics and anti-inflammatories. Anticholinergics work for rescue medications or are part of the rescue medication group, and anti-inflammatories are part of the long-term control meds. Under anticholinergic meds, you have inhaled short-acting anticholinergics, and they finish in IUM. The most common one is ipratropium or tropium. Most of the time it's combined with an albuterol. And how they work is that they relax this muscle, this smooth muscle in your airway. So that way it relaxes and dilates your pipe or the airway. It could be a secondary alternative to SABAs, but again, I see them constantly being given with SABAs. There's something called Duanib, and it has basically anticholinergics and a bronchodilator. Now, on the other hand, you have your long-term anti-inflammatories. They're inhaled corticosteroids. They're steroids that go directly to your lungs, and they finish in SONE or NIDE. Most common are fluticasone and budesonide. The important thing to remember about steroids is that when you inhale them, they kind of stay in your mouth. And so it's very important to rinse your mouth or use a spacer. And that's the photo that is there. That's a spacer, because they increase the chance of patients developing thrush, which is a yeast infection in the mouth. They could cause cough and hoarseness. It takes a while for them to react, so that is why they're not used as rescue medications. They're long-term, and they can also decrease immune response. Patients sometimes are given oral and IV corticosteroids as well. Just kind of depends on the physician, so just keep that in mind. Sometimes they might have a inhaled corticosteroid plus a oral like prednisone. But again, they finish in zone or NIDE. This additional class here that we're going to talk about, it's not commonly used anymore. It used to be commonly used, but the book talks about it, and also NCLEX still tests over it. So therefore, yeah, I talk about it too. So the classification is methylxanthines. Most commonly one is theophylline. They finish in thylene. Not the first line of treatment. And the problem with this drug is it's a troublemaker drug. It conflicts with a lot of things. It has toxicity risks. So that is why I think it has gone away from being given to patients like it used to. But you might see it. I just don't see it that often anymore. The risk for toxicity or the symptoms of toxicity are nausea, vomiting, seizures, and insomnia, GI problems, and tachycardia. You have to avoid caffeine, and many drugs interfere with the metabolism of the drug. Now, there's another different classification that also hangs around on its own, but it's very commonly given in asthma, is this Lucatrine Modifiers. The most common one in that class is Montelukast. They end in cast. You probably have heard of it, singular. They're used to control in kind of maintenance therapy, prophylactically prevent asthma attacks. They're not used for acute attacks because, again, it takes a while for them to start working, but they prevent asthma, and it's a maintenance therapy. They should be taken 1 hour before meals or 2 hours after meals. And I've seen it where patients have struggled with albuterol for a while, and then they put them in Lucatrine Modifiers, Montelukast, and they do very well, and their asthma gets under control. So now let's talk a brief general review on how to use an inhaler. But again, I need you to go into the pages 553, 554 to 555 and really read detail on what you're going to educate your patient about how to use one of these. So there's two different classes on inhaler, your meter dose inhalers and your dry powder inhalers. Let's talk first about the meter dose. Your meter dose are the ones that look like an L, so pretty much like this. You have to shake them very well. If it's your first time using it, you shake it very well. You do a prime puff. So you press on it and you prime it first. Then you have to position it very, very well and correctly in your mouth. You want to have it at 90 degrees. The reason for that is because you don't want the medication going to your palate. You want the medication going to the back of your throat so you can inhale it. You breathe out completely your air. You position yourself very well, straight up. Breathe out, then position it in your mouth and press on it and breathe the medication slowly and deeply. Hold for 10 seconds and breathe out slowly. You want to wait 1 minute between each puff. Most of the prescriptions say 2 puffs for patients. Now, on the other hand, you have your dry powder inhalers, and they usually come on like a disc, something circular, just like the picture you have here. It has a position for your mouth, just like the picture here. But you have to load the medication. It has like this slide thing that on top of it, and you just slide it and it loads the medication. You don't shake it. You seal your lips around the mouth and quickly take a slurp of air very quickly, like just like that. So you breathe deeply and quickly, and then you hold it for 10 seconds. So those are the main difference between them two. The next thing that you want to teach your patient is what is the difference between a nebulizer and a spacer, and why do we use a spacer? A lot of patients get confused with that. So let's talk about a nebulizer. I have a picture here. It's a machine that creates and converts this drug into a mist that patient can breathe. It's usually done either through a face mask or a mouthpiece that you just put in your mouth. Patient has to be upright, breathe deeply and slowly, and hold for 2 to 3 seconds. You have to clean the mask or the mouthpiece with soap and water and allow it to dry. Now, a spacer is this device, and I have a picture here. Let me go back to it so I could describe it to you. You put the inhaler into the actual spacer, and we use spacers for people like children that don't understand the fact of breathing deeply and holding your breath, or maybe people with dementia, elders with dementia that might not understand how to do that or might not be able to do that. The purpose of a spacer is just solely to deliver the medication correctly and effectively. So that way, think about telling a child, breathe out, breathe slowly and deep in, and now hold. They might not be able to do that. So then you waste the medication in the air versus if it's contained within the space of the spacer, the child can just breathe, or the elder can just breathe slowly and not waste the medication. That's the reason for the spacer. So improves the amount of drug delivered to the lungs. It is used in children and elder, and people can just breathe normal. Here's an easy to read of asthma. Welcome to pause it and take some notes. And then we move on to chronic obstructive pulmonary disease, ACA, and commonly known as COPD. So what is COPD? Well, first and foremost, it's a chronic lung disease. But here's the thing, it's preventable, but it's irreversible. It's not reversible versus asthma. It's reversible in a way. Another thing of obstructive pulmonary disease is that it's progressive. It gets worse and worse. Okay, so it's preventable. It's a chronic, progressive, and irreversible inflammatory lung disease that is characterized by persistent airflow limitation. There's many factors that lead someone to obstructive pulmonary disease or COPD, but the number one reason and the number one factor is smoking. However, you have other factors such as asthma, infections, occupational exposure to respiratory irritants. So somebody that works with fine dust or is a miner. Air pollution also, cities that have a lot of air pollution. It is more common in men. It is more common in white people and very little presence in Hispanic. Lots and millions of people suffer from COPD, and it's the third leading cause of death in the United States. Okay, so let's talk about a little bit about the pathophysiology. What's the problem here? So we have these irritant particles or gases, right, that over time damage the lungs, and it creates this inflammation. It creates airway obstruction. It destroys the alveoli, which is the parenchyma, is a functional part of the lung, and damages this vascular vessels in your lungs. That leads to airway flow limitation, mucus hyper secretion, loss of elasticity. Oh my God, I can't talk today. Sorry about that. Impaired gas exchange. I mean, it leads to a complete destruction in a way of your lungs and airways. And also physical manifestations on patients. And I'm going to show you here in a little bit kind of how they look. So here's the picture. You got your normal alveoli, and then they get all hyperinflated and just lose shape and elasticity. Then you have your airway normal, way open, big lumen, and then it becomes all filled with mucus and inflamed, and airways are narrow. Your smooth muscle also it's affected, and you get fibrosis, and the smooth muscle gets contracted. So again, that doesn't help for the airway to be open. And so what happens is that patients can't expel carbon dioxide, and then they hold it on and they hold it on. So the manifestations are slow, but they're progressive and they're chronic. Few manifestations are hallmark, and I kind of have put them in with your stars. So you have this intermittent chronic cough that can be wet, but not always. So some have sputum production and some don't. You have difficulty breathing, especially with exertion or activity, physical activity. You have wheezing because, again, the airway is narrow. Your breath sounds are decreased. You develop this barrel chest, so very wide in your thorax, at the top of your thorax. People start sitting kind of forward, like in a tripod position with their hands on their knees, and they kind of go forward like this, like I'm doing right now, because they're trying to get air inside. Their nails become clubbed, kind of like thick, and also the nail just becomes like outwards. I'll show you in a picture in a minute. It can and it will affect your cardiac system. So you'll develop some swelling of the ankles, and also because of the lack of oxygen that is coming in, you might have discoloration of your skin and your lips, etc. Here's the barrel chest and the tripod position and the clubbed fingers. Okay. Here's that easy to read kind of COPD. You're welcome to pause it. And then let's talk about how we diagnose it. Well, again, the history and physical of the patient is very important, but in order to diagnose COPD, you have to do a spirometry. It is necessary to be done to be diagnosed. And basically, it's going to show how severe and how obstructed is the airway. You can do a chest x-ray to look at the lungs to see how hyperinflated they are, and also your heart. You can do ABGs to diagnose respiratory acidosis because they're holding on to a lot of carbon dioxide. You can also do oximetry in a 6-minute walk test. In a 6-minute walk test, what it does is that we make patients walk without oxygen on and see what their oxygen level drops to. Then we put oxygen, make them walk, and see if they could hold their oxygenation level. So that's another thing that they could do, just to basically find out if they need oxygen to go home. Here's an overview of the management that we do with COPD patients. Most of COPD patients, we treat them outpatient. They don't have to be hospitalized all the time. We only hospitalize them if they have an exacerbation of acute COPD. And most of the time, a patient has COPD exacerbation is because of an infection, most of the time. So therefore, Early vaccination between influenza and pneumococcal or pneumonia is very important. We want to educate them to stop smoking because, again, it's the number one reason that they develop this. So the more they smoke, the more it damages their lungs. We also want to encourage lung expansion, which is going to be the tripod position or elevating the head of the bed. Then we give them medication, and they're going to be in several of these medications that we kind of previously talked, but that I list them here. You can basically remove the CO2, the carbon dioxide, by encouraging and teaching your patient how to do pursed lip breathing. So again, pursed lip breathing is like you're going to kiss someone and you just put your lips like this and breathe out. That encourages the CO2 to be expelled from your lungs. You are going to be working with physical therapy to help the patient regain strength and learn how to walk and breathe at the same time. You're going to provide them supplemental oxygen if it's needed. But let me allow me to refresh and review that the problem is not oxygen. It's not that we're going to give them oxygen and fix them. It's that they're retaining CO2 because their airway is obstructed and their alveoli are not exchanging. They're not doing that carbon dioxide and oxygen exchange. We're going to also do something called CPT, chest percussion therapy. It's like tapping the chest, and it's to break the mucus and helps with airway clearance. We're going to encourage them to have a good nutrition, high on calories, protein. These people get exhausted when they eat, and so they basically try not to eat because it's hard to eat and breathe at the same time. So we're going to involve, dietitian, nutrition, all those, and do effective coughing techniques such as huff coughing, which is a fast, strong cough, like like that. You're going to see that a lot of patients with COPD are not necessarily going to have a oxygenation level of 100% perfect. Your most COPD patients range between 88 to 92, and that's an acceptable level for them. They live on that range. So the goal for supplemental oxygen is to maintain levels above 90% or maintain them to what they're used to be at, okay, prior to getting sick. We're going to review the medications quickly because I have just discussed them little by little, one by one. They're going to be given anticholinergics. They end in PIUM, ipratropium. It can cause blurry vision, dry mouth, tachycardia, and urinary retention. You're going to have anti-inflammatories to decrease that inflammation that happens in the airways, and they're going to be inhaled or given orally or IV. Remember the rinsing of the mouth. You're going to have your bronchodilators to help your airways and your pipes get dilated so they can get more oxygen and expel the carbon dioxide out. Think about central nervous system as a side effect, tremors, high blood pressure, and tachycardia. And that's pretty much, the medication except for oxygen therapy. So oxygen therapy, it's on page 568 of your book. What I want you to do is that I want you to review the goal for supplemental oxygen, again, above 88, 90%. Oxygen does not fix the problem, okay? Don't forget about that. However, there's a couple of things that you want to know about oxygen. There's different ways to deliver oxygen, from a simple mask to high flow, nasal cannula to a nasal cannula to a non-rebreather. So you as a nurse need to understand which delivery we use for what and how many liters can I do on each delivery. So for example, I have a patient on nasal cannula and I want to give him 15 liters of oxygen. No, that's not possible. And the reason for that is because a regular nasal cannula can go up to 6 liters or 5 liters. Keep in mind this this picture that I have here might not be updated to what the book says. So this is just for reference only. Just go in your book and update the liters that your book says. So what we will do on that aspect is that maybe the patient might need a high flow nasal cannula. They can go maybe up to 15 liters. Another thing that you want to remember about oxygen is that when you walk into a room, you want to make sure that you are reading how many liters the patient has on, and you read it with the flow meter here. That flow meter, the picture that I have there with the green tree, we call that the green tree. It's on the walls, and so you want to read where the ball is on your liters and basically find out how many liters. You also want to make sure it's there. Check the skin integrity of the patient. Like if they have a nasal cannula, sometimes they break down their skin right here underneath their eyes or their ears. Another thing is providing humidity. A lot of this oxygen just basically dries their mucosa. So providing some humidity for the patient, as well as making sure whether they're in the hospital or they go home on oxygen, that we educate them that they cannot smoke. It's flammable, as well as they need to use, like if they're using something to keep their lips moist, it has to be water-based, not like Vaseline, let's say. So there's a couple of things. There's a few things in education that I want you to review when it comes to oxygen therapy. Another thing to take in consideration is their nutrition and their ADL. So energy conservation and nutrition. We might need to help them with their ADLs because they get exhausted from being unable to breathe. Like simple tasks as bathing, dressing, or cooking. And so they might need to take rest periods in between, or maybe do it at a certain time of the day or after they have a bronchodilator treatment. Same with nutrition. It's exhausting to eat and not being able to breathe at the same time. So rest 30 minutes before eating and using a bronchodilator. Try to get them moving to increase their appetite. Avoid activities 1 hour before or after the meal. High-calorie protein meals. Apply oxygen as needed. Give them what they like favorite meals and snacks, because at the end of the day, we want them to eat. And eat often in the day. So it might be smaller quantities, but often, like between 5 and 6 meals a day with supplemental drinks like Ensure. Careful with narcotics. So let's say this patient has COPD, but also has a back pain, and you have to give them a painkiller. Well, they might not be breathing as fast. They might be taking shallow respirations because they're medicated with painkillers. So you want to be careful with those that depress respiratory rate, and try to avoid them if you can. I hope this was helpful. A little review on COPD and asthma. Again, always, as I always say, my reference are from your book, and all images are from Google in your book. Hope this is helpful, and we'll see you in the next video.